All right. Hello, everybody. Um, while Professor Göksel is finishing some details in his presentation, I'm here to talk to you a little bit. Yes, people from all over the world. Thank you, USA. Thank you, Ziad. Thank you, my friends. Carlos Rocho, thank you, my friend. Always here with us. Thank you. People from Argentina, Mexico. Saludos, Mexico. Saludos, Argentina. Great, great. Excellent. We just started and more than 100 people. Thank you so much. Well, just while we finish there, um, just a second here. Yes. Well, while people come in, right? I just want to, oh, people from Turkey also, Paris, great. I think this, Indonesia, thank you. This time for the lives is really, really amazing because we can get people from South America, Latin America, and also people from Europe and people uh, from Japan, Australia, all people from all over the world. Barcelona, great. Thank you so much. Iran, great. A lot of people. Thank you. Um, well, first of all, before we start with Professor Gossel, I would like to tell you that after this live, we have another live at 5 p.m. Okay, but just for people approved, people who were approved in our online mentoring program, because there are some people with doubts, and because we had so many applications, much more than I thought. I'm not able to talk to each one in person. So I'm answering all the questions that I can, all the messages. I'm answering all the emails that I can. But I found an interesting way to put everybody together and answer all the questions at the same time. Okay, so 5 o'clock Brazilian time, I'm gonna answer the questions for just for people who were approved in our online mentoring program and in the meeting, and you should have received your link. All right, and also the last thing, we just have we're gonna finish our application forms tomorrow, okay? Because we have so many applications so far, and I don't wanna. I wanna keep the quality of our mentoring. So I'm not interested in so big numbers, right? I'm interested in giving you the best experience. And all right, so let's invite Dr. Goksel here, and of course he doesn't need to be an introduction, but let's put him here to talk to us. Almost 200 people already. Thank you so much. People from Italy, great. Alessandro, grazie. Yes, some questions already for Dr. Goksel. Let's leave it for the end, okay? Dr. Kazim, leave for the end, and we can answer as much questions that we can. And Buenos Aires, great. Okay. All right, Professor Goksel, how are you? Great, nice to see you here and to have you.
Hello. Hi, everybody. Good. Thank you. How are you? Fernando, you look great.
Oh, thank you so much. It's a really great pleasure to have you here. We
Oh, thank you.
yeah,
It's my pleasure, actually.
thank you. People from all over the world, of course, they know you and they are here today to learn a little bit more from you. What I say in every single live that we're doing, I'm receiving a lot of amazing feedbacks from our friends and colleagues because the format that we're doing here is an opportunity to have a long contact with you and have time to understand your all the steps that you followed until you get in your high level, the highest level in rhinoplasty, and also to learn some things about your philosophy, the way you think. And we really have chances to understand that in a way that we never have when we're in a meeting. So this is amazing, this opportunity. Thank you so much for your time.
Thank you very much for the invitation. I follow you. You're a hard worker. You're doing unbelievable job. Almost 2-3 times a week, you have live broadcast with famous rhinoplasty surgeons. I'm also enjoying about these lectures. We all learn in our career. I mean, it doesn't matter which level you are, you're always learning. Sometimes I learn some small details from my fellows, so it helps me. So all kind of knowledge, small details are really important in rhinoplasty. Sometimes it saves your life. That's why it's better to listen if somebody is talking and giving some ideas, sharing the experience. It's really important. So we are going to talk something about preservation rhinoplasty mostly, but rhinoplasty is not just the preservation rhinoplasty. It will be all concepts which we are going to talk, but mostly open preservation and also anatomy of the nose. It's actually interesting. When I started to learn anatomy, I thought that anatomy cannot improve, cannot change. Actually, anatomy is not changing, but we are discovering something new, and it's unbelievable. It's so amazing that every day, once we change some approach, once we change some technique, we realize that there is something important, small details. It was there, but we were not able to see. Now we see. That's why today I will share some interesting anatomic landmarks for the preservation rhinoplasty, because we were not familiar from this point of view. The view changed, then the anatomic landmarks are changing for the technique.
Great, great. That's amazing. Something I always pay attention in is how exactly what you said, and exactly all the great surgeons always say. It's a never-ending process in rhinoplasty, and you see,
Exactly.
you're so expert in rhinoplasty, but you say that you're still learning some tricks and some things that you can put in your practice. So that's amazing. And before we start, Dr. Göksel, I will do a brief introduction in Spanish and Portuguese, okay? Because we have a lot of people from
I will.
Latin
I will try to understand.
America. Entonces, muchas gracias, amigos. Mucha gente acá de toda América Latina que están siempre juntos. Y ahora una gran oportunidad de tendremos acá un gran cirujano que es el profesor Göksel. Ya todos saben que tiene mucha experiencia en rinoplastia estructurada, rinoplastia de preservación y también el abordaje de rinoplastia de preservación abierta. Entonces, hoy vamos a hablar mucho de esto y espero que a ustedes les guste. A um amigo de todo o Brasil, mais uma vez queria agradecer a presença de todos. Todos esses dias agora de quarentena têm sido maravilhosos, né, nesse ponto de vista. Por um lado a gente perde, mas por outro lado a gente tem tido grandes oportunidades de talvez aí uma mudança para sempre do modo de ensino médico, né, da forma como vem sendo feito. Todo mundo vendo que pode se atualizar e ter excelentes palestras no conforto da sua casa, né, e se atualizar de uma forma eficaz e tranquila. So I was saying that it's amazing how the situation of pandemic brought some bad things, but a lot of great things, right? Because
Yeah.
these days we're learning so much, maybe like never in the last months, because we have in the comfort of our home, we have the opportunity to meet people like you and all the great surgeons and learn a lot from these discussions. And it seems that we're far, but at the same time we're close, because all these things let us close together to learn more and more and improve ourselves in rhinoplasty. So that's amazing to have this opportunity. And as you were talking about this, Dr. Göksel, and before we start our conversation, I will show here for people. It was so amazing this moment. 3 months ago, I was with you in Istanbul, and we had dinner with Nazim and Baris, and it was so amazing. And like you said, just to show a brief moment here, and let me put this window here. here we were together, okay? But can you see that?
Yeah, of course, I see that.
I That's not exactly what I want to show. What I want to show is related to what you said now. It was amazing for me because I was in exactly there in the dinner with you guys and you two experts discussing about details of the ballerina maneuver that you described and also uh, how much each one was releasing the key area. So that was really, really fantastic to see that you were always improving, you were always looking for the best for your patients and discussing details, like you said, and learning from each other some tricks. And that was really, really amazing. So that was a great moment for me. And just to share a little bit with our friends here.
Oh, thank you for reminding. It was really good moment, and it was a great night. And also, I want to get your attention about that photograph and video. There was no mask.
Yeah, yeah.
So I miss normal life. I want to go to restaurant with friends and discuss something about details of rhinoplasty.
That's it. That's it. All right. So, Professor Gok, so let's start here. You're during your journey, right? You started. Tell us a little bit. You started with close approach or open approach, and on one certain time you were doing structural rhinoplasty. And how was this change for preservation concepts?
Uh, Actually, for the young surgeons, it's interestingly that we all started as experienced surgeons. We all started with close approach. So I did close approach in my career, 5 years. Then I switched to open approach. Then I thought that I was blind before. Then my eyes were open that moment. Then I started to see everything what I'm doing. So it was amazing. So open approach changed a lot. We learned a lot. We started to teach easier because it was possible to show exactly what you're doing inside of the nose. Then because of open approach, now we started again close approach because we learned a lot, we taught a lot, and it was visible, it was easy to understand. Then we now decided to do same maneuvers with close approach. Actually, it's amazing how we improved in this period because I started with close approach, and when I see my results about 25 years ago and compare with the open approach results were much better. Then now I learned open approach, a lot of maneuvers from experienced surgeons, from masters, from Bahman Guyron, from Dean Torimi. I learned a lot. Then I repeat a lot of maneuvers and we add a lot of maneuvers on it. Then now I do close approach also. About 30%, 40% of my cases, I do close approach. And still majority, I do open approach. Why I open the nose? Because when I open the nose, I see the tip of the nose clearly. Everything is on the midline. I can fix it easier. And for non-experienced surgeons, it's easier to understand and it's easier to learn. But now I do open approach with preservation. I do open approach with preserving the ligaments. So sometimes I respect the natural anatomy in open approach more than the close approach, because sometimes in close approach you cannot preserve scroll area, but in open approach it's easier. So it's interesting. So time is changing, techniques are changing, and everything is based on our experience and knowledge actually. So I cannot imagine that 25 years ago we could do this preservation rhinoplasty. Preservation rhinoplasty doesn't mean that keystone preservation.
Okay.
Preservation rhinoplasty is a concept altogether. Of course, it's really important. Preservation rhinoplasty grabs some nice tools from the dorsum preservation and grabs some nice tools from Barış the dissection area, subpericondrially, and grab some ideas from me, from others. Open preservation rhinoplasty is kind of mix. So the difference between the open and closed approach is not just the incision, actually. The important difference between, as a disadvantage, I can say, you cannot preserve easily the superficial layer of the midline ligament. But the deep layer of the midline ligament, pitangul ligament, it's easy to preserve in open approach. But from my point of view, the most important midline ligament is the deep layer of pitangui, because it's the strongest one. But sometimes I feel that the superficial layer is also important as a camouflage, because it makes everything together. So that's why I do 40% of my cases close approach.
Yeah, that's amazing. And also, I remember you discussing this with Nazim on that dinner in Istanbul, exactly about that, because you don't do the closed approach as we used to do in the past, right? It's a totally different closed approach nowadays. And also, we don't do, not that we don't do, but we do an open approach a little bit different also than we were doing some months ago, because we're preserving more and reconstructing more. And that's really exciting to see these changes, right?
Yeah, it's really interesting. We were discussing with Nazim in that dinner, because once we talk about the close approach, we were always thinking about reduction close rhinoplasty. So it was so fast, and actually it was so routine surgery for us: hump reduction, osteotomy, cephalic trim, and then almost operation finished. So a lot of reduction, close approach rhinoplasty, we did revisions. So we learned with open approach how to reconstruct the middle wall, how to do better tipoplasty. Then once we switch back to close approach, we repeated all these maneuvers in close approach. Of course, in open approach, it's easier, by the way. But in close approach, maybe it's easier also to make camouflage, because once you don't destroy the superficial layer of pitangui midline ligament, so it's kind of a natural camouflage by itself.
Great. And yes, and you were talking also about your preferences in some cases to do an open preservation, right? And you already said that, but it's important for younger surgeons, or especially for people who are starting preservation. People sometimes they have a wrong concept. They say, "Oh, preservation is like going back to close approach," and it's not. Like you said, it's not a technique; it's a philosophy. It's a sum of concepts that you put together, and it's not really that. And I know you're gonna show here, and if you would like to show a little bit of the anatomy for open preservation for people to understand that.
Yeah, I think it's easier if I show something, because otherwise I will talk, but we are working on some visual things. It's better to show something. I can share my screen.
Yeah.
Then I will try to do that. Okay. Is it visible for you now?
Yes, it's perfect.
Okay, great. So I want to announce also, nowadays there are a lot of webinars. European Academy of Facial Plastic Surgery has really wonderful program. Almost every week, 2 or 3 webinars they have. And yesterday there was a really nice discussion. I want to thank the Roland Daniel, because he named this technique preservation rhinoplasty. Then it became popular. It's really important. So let's start with the anatomy. This is from Peter Palhazi's library. All these drawings are important because these are the borderlines of the anatomic landmarks: the lower lateral cartilage, upper lateral cartilage, the scroll cartilage between. And let's pay attention to the bony cap here. Once we remove the bony cap, you can see the overlapping area. This is the upper lateral cartilage. Still under the bony cap, we can see almost 1 centimeter overlapping here. It's amazing. because
Yeah.
we were always removing this part. We were just taking out. Now, with the preservation, dorsal preservation techniques, we can keep it intact. And this is the dorsal keystone. This is the lateral keystone. As you see, there is an overlapping area. Yesterday night, there was a webinar, European Academy of Facial Plastic Surgery, and somebody was asking about this overlapping area. Once we elevate, once we do ballerina maneuver, which I'm going to mention, do we have some risk of collapse or inverted V? Actually, once you see this photograph, you can get the answer easily because the overlapping is huge. Once you just undermine, I'm not talking about cutting, just undermining the lateral keystone area here, you're just making the relax of the movement of the dorsum. So the attachment is actually immediately happening, then you don't have any risk. So I don't see any problem after ballerina maneuver from the top. So at the end of your career or experience, you will decide to preserve or not to preserve. This is really interesting video. We were not talking about these compartments before. I just want to show again. As you see, there is a alar compartment. We are working on with Dr. Yves Saban, this compartment. So we described, we wrote actually the paper, but didn't publish it. That's why we have to wait the paper before. But I just want to show you the compartments. We have compartments on the dorsum. You can say two compartments, the tip compartment, alar compartment, and the dorsal compartment. But dorsal compartment also is separating with the piriform ligament here. This is the vertical piriform ligament, which is connecting the nasal bone, piriform apertura, with the skin. This is really important. Then you can say that this is the middle third, this is the upper third. Then we have three different compartments. If we don't need to do anything on the dorsum, why we have to destroy all these ligaments? Why we have to make a one huge space under the skin? So because redraping will take time. This vertical scroll ligament and the vertical piriform ligament is connecting the skin with the skeleton. If we can do our job with preserving them, healing is faster. There is no doubt. But of course, the main goal is in rhinoplasty, have a good result.
Yeah.
If you can achieve a good result with preserving these ligaments, it's even better. Of course, if you cannot get a good result with preserving, because sometimes you have to change a lot, you have to reconfigure the nose, and you have to change the location of the ligaments, then of course we can cut these ligaments. It's not the must, but if you can preserve, it's better because healing is wonderful. Even after 1 week, you cannot believe your eyes that healing is so fast.
Yeah.
And this is Pitanga midline ligament. It's a huge ligament here in front of us. What happens once we cut it? And this is the deep layer of Pitanga. As you see, the attachment is between the medial crura and the also cephalic margin of the lower lateral cartilage is the attachment here. Once we cut, I will show you later how it works. And this is the scroll. And this is the Pitanga, deep layer of Pitanga. If we can keep intact here, we don't need to go to the second or third compartment on the dorsum. So open technique lets us to preserve all these ligaments. As you see, this is the open approach. I open the tip. I just open the first compartment, but I do use piezo because once I do preservation rhinoplasty, I prefer to use piezo because I want to make precise cut on the lateral. So lateral osteotomy is really important because the direction of the lateral osteotomy is important for me. I will show you why. And how we can approach to the lateral osteotomy site. Because if you use piezo, you have to see more, you have to undermine more. Then this is the piriform of apertura, black dots line. as you see.
Yeah.
So we can approach directly through the preform apertura. This is the Webster triangle. We usually resect this triangle in this approach because otherwise there is a resistant point, overlapping point between the inferior turbinates bony fracture. Then we approach the lateral osteotomy line through here. This is really interesting and important anatomic photograph. Actually, we discovered with Peter Palhazzi, there is another ligament attachment between the skin and the skeleton, exactly on the suture line between the frontal process of the maxillary bone and the nasal bone. And I call it nasomaxillary suture line ligament. So this is vertical preform ligament, and exactly this ligament is so tough, so strong on the suture line level that it continues with the suture line ligament. Actually, it's normal because maxillary bone and the nasal bone has two different periosteum. So there is a connection point. Where is the suture lines? There is always difficulty to undermine. But this attachment is important. Why? It was not important before because we didn't care. Because we were just undermining the dorsum. We were just resecting the bony cap or hump. But now, if we preserve this ligament, we don't need to undermine all dorsum. That's why the tunnel I created before, the two photographs earlier, I showed you the tunnel. Yeah. It's under this ligament here. So we don't deattach this ligament. We don't cut this ligament also. So vertical preform ligament and nasomaxillary suture line ligament, they are all intact. If you approach through the preform apertura and create your tunnel for the osteotomy. That's why this is really important. And once we cut the petangle ligament, it seems like it's a thick ligament. Yes, sometimes it's thicker, sometimes it's not. But once we cut, as you see, it's really white radix here. It's exactly on the supratip area. So that's why I prefer not to cut petangle ligament. But sometimes, of course, you need to cut petangle ligament. If we cut petangle ligament, if the patient has thick skin, I prefer to excise all the remnant under the skin. Then I prefer to cut close to the skin in this case. But if patient has medium or thin skin, I prefer to cut on the midline. Then I refix at the end of the surgery. And this is also interesting. Once you mark the petangle ligament all around, as you see, there is a round shape under the skin. So this is vertical preform ligament, and this line shows the suture line. There is another attachment, as I showed you in the previous photograph.
Yeah.
So this anatomy is well known, but we were not paying attention this much because of the approach and because of the technique. So this photograph, I described 3 different approaches in open approach preservation rhinoplasty. The first one, when we call it easy case, it means that the nose is straight, there is a small hump, less than 4 millimeters. We just reduce the hump and make a tipoplasty, that's all. In such kind of cases, we don't need to cut anything. I mean, we don't need to cut scroll ligament, we don't need to cut petangle ligament, and also nasomaxillary suture line ligament can be intact. We just undermine this red marked area. So I open the first compartment, alar compartment, and I go through the preform apertura, I create my tunnel, and I do my radix osteotomy externally, then it's done. We can do low septal strip, we can do high septal strip. It's another issue. It's on the septum. But for the dorsum, we can approach the dorsum this way. So we can keep intact all these ligaments and anatomy. And the second group, if you want to change something on the dorsum, sometimes you need to add some camouflage graft, or sometimes you have to trim a little bit the cartilage or rust bone, and or you can do cartilaginous preservation, so you need to rust the bone. Then we can still keep intact the scroll and phalangeal ligament. Here, between them, we can approach the dorsum. So again, the nasomaxillary suture line ligament will be intact, and also scroll ligament will be intact. So healing is again faster. But sometimes you can still do preservation, dorsum preservation, but you need to do more. It can be crooked nose. You should change the shape of the bones. You should do sometimes osteotomy and equalize the lateral walls. Then in such kind of cases, of course, I don't preserve. I do extended open approach. Then at the end of the surgery, it depends on the skin type. I refix the phalangeal ligament or excise the phalangeal ligament. So these three different approaches are important in open preservation rhinoplasty for me. So this is my typical inverted V incision. This video is also nice to show how I just opened the tip compartment. You can sometimes preserve this superficial layer of the phalange here, as you see, but it's not easy for all cases.
Yeah.
This is, I will stop here. This is interesting. Supraperichondrial or subperichondrial? What do you prefer?
You're in my cases, you mean?
No, I mean in regular rhinoplasty, standard rhinoplasty in your operation theater, do you prefer subperichondrial or supraperichondrial dissection?
In my cases, it depends on each case. I'm trying to go suprachondral whenever I can, but in some thick skin patients, I think it's more difficult, and I try to go subsmass.
Okay, if you need to excise the smash, of course, there is no logical reason to go subperichondrial way. You're right. But especially for thick skin patients, I don't want to touch the smash. That's why in that cases, I still do subperichondrial dissection. This is supraperichondrial dissection. As you see, the cartilage looks so nice. There is no bleeding because real supraperichondrial dissection is also not easy to find the plane. And I will show you the trick for real supraperichondrial dissection, which I cut. It was a superficial layer of the phalange. Now I will show you the trick. The second hand always hold the hook. As you see, I'm putting my hook so close to my dissection area and pulling up. Then I'm undermining with my scissor. This small trick helps me to find the correct plane. Otherwise, you can see a lot of bleeding or some smashed tissue can be on the cartilage. Then this is pure supraperichondrial dissection, but it's also bloodless, as you see. When I go under the perichondrium, of course, it's completely bloodless plane. The color changed to the pearl. This is a little bit bluish. But anyway, these two planes I do use in my operations. And when the patient has very thin skin, I prefer to go subperichondrially. And when patient has thick skin, also I prefer to go subperichondrially because I don't want to irritate the smash, because a lot of sebaceous glands are inside. Once you touch them, there will be always some secondary healing, sebaceous hypertrophy. So you get always respond from the skin. So that's why I don't want to touch the skin when the patient has thick skin. So as I mentioned, I have two different groups. In the first group, I showed you the dissection plane like this. This is the red dissected area. So we don't undermine the phalange and the scroll ligament. We approach the osteotomy tunnel through the piriform apertura. Then I still use my piezo instrument, as you see on the video.
Yeah.
So this is the tunnel, and all ligaments are preserved. Even nasomaxillary suture line ligament is preserved. So I create my tunnel. I just want you to pay attention. The direction of my osteotomy, it's sagittal. It's not horizontal, as in classical rhinoplasty. It's really important. And this is the way I use my instrument. And this is Eren Taştan and Barış Çakır's saw, hand saw. It's really useful instrument for the transverse osteotomy. In group 1 patient, I cannot use piezo for the transverse osteotomy because it gives heat, so I can destroy the skin. That's why after completing low to low sagittal osteotomy, I do use this hand saw, and I keep intact the radix. I don't undermine the radix skin, and it gives me stability when I do radix osteotomy. Then I do this is hand saw, and after hand saw, as you see, it's like piezo. It's really sharp, nice cut with hand saw. On the other side, I can show you how it works. Once you use first time, you will find it's not easy because you have to get used with your hand. It should make this maneuver, but once you get used, it's really easy. And what I do in the group, first group 1 patients, I do oblique way radix osteotomy, so it creates hinge here. Then I don't have any step on the radix. And this is the end point of my surgery. I'm not talking about anything on septum now. I'm just talking about the dorsum preservation, the nasal bones, and how to manage the osteotomies. Because I do high septal strip, low septal strip, mid septal strip, depends on the case and depends on the septum. It's always confusing people because once you're talking about the preservation rhinoplasty, some people think that it's just high septal strip operation or it's just the cotal operation, but it's not. It's just the septal work. So you can combine all this kind of septal work with additionally let down, push down, or cartilaginous and ligament preservation techniques. But what I do, it's really interesting actually. Even if I do supraperitoneal dissection, for me, it's important to preserve the attachment of the scroll ligament here. Then I go always in preservation rhinoplasty techniques. I go always, even if I do supraperitoneal dissection, under the perichondrium at the level of the cephalic resection. If I'm going to do cephalic trim, cephalic resection, I go under the perichondrium at the level of the cephalic resection because the scroll ligament attachment is attaching to the perichondrium, not directly to the cartilage. So once you go under the perichondrium, you're keeping intact these attachments here. Then it makes sense for me to go under the perichondrium exactly on the level of the cephalic portion. Then I can resect my piece of cephalic portion of the lateral crura. Then I can still preserve the cartilage. Of course, if you go under the perichondrium from the beginning, you don't need to do this maneuver. You're already under the perichondrium. But if you go over the perichondrium, it's better to go under the perichondrium at the level of the cephalic resection. It was also interesting. So this is an example for group 1 preservation. As I mentioned, it seems like it's an easy case. The small hump, and you don't need to do a lot. I don't need to cut any ligament. I will just reduce the hump and make a small tip plasty. So this is the result pre and post. This is early result actually. Interestingly, the healing is so fast because I didn't undermine the skin on the dorsal. I didn't cut any ligament here. And this is the profile of group 1. As I mentioned, there is a group 2, which we have to do something on the radix or the dorsum. We have to approach the dorsum. And this is red marked area is undermining area and green marked untouched. And this is white one scroll ligament and pitanga. Between them, we can approach the dorsum. How? This photograph shows us clearly. This is the pitanga ligament green marked, and the yellow mark is this vertical scroll attachment. So between them, if we create a tunnel, we can approach the dorsum. We can put some grafts, we can rasp, we can reshape the dorsum a little bit. Then we can do some modification of the dorsum, but still we can preserve the ligaments if you need to. If you don't want to preserve the ligaments, of course, you can cut from the beginning. You don't need to make torture to yourself, but this is also possible, which I do a lot in my practice. So group 2 preservation with open approach. This is a good candidate because I have to change something on the dorsal aesthetic lines. There is no symmetry here. So this is pre and post photograph. Still healing is fast because attachments are intact. Only one disadvantage I can say about this group 1 and group 2, you don't dissect the dorsum, you don't destroy the ligaments, so the dorsum heals faster.
Yep.
But the tip of the nose swells first month a little bit more than the dorsum, so you have to warn your patient that it can happen. I don't have any problem because I'm telling my patient that tip swells more from the beginning, so they accept. So the preservation group 3, I don't need to keep intact the ligaments, but at the end of the surgery, I can fix them back if I need. So this is extended open approach, which we were doing for years for piezo surgery. Actually, I started to do this approach in 2014 with Dr. Olivia Gerbo. Then this is an example. You have to change a lot. You have to reshape the dorsum. You have to put some camouflage grafts. Then no need to make torture. You can cut the ligaments at the end of the surgery. You can refix the pitanga ligament on the place. So this is kind of easy diagram how I decide how to preserve. If I decide to make preservation rhinoplasty, these 3 groups are like this. And if the dorsum is straight, septum is straight, I go with the preservation group 1. And if I need to change something on the dorsum, I still preserve the ligaments, but group 2 patients. And if I need to do a lot, and there is a asymmetry, severe asymmetry, I have to do group 3 patients, so it's extended open approach. By the way, please stop me if I'm prolonging a lot, because maybe we have limited time, because I can talk hours and hours about this issue because I concentrated so much. Then please stop me.
Really enjoying the proof of that we have almost 500 people really focus here. You can
okay. I mean, you can please don't hesitate to interrupt me, because when I start to talk about this issue, it can take hours. So I want to share my own experience, because when I started preservation rhinoplasty, I also struggled. I was experienced surgeon, so I was asking myself, do I have right to start a new technique? Because I had already nice results with my previous technique. So I asked myself, what's the advantage? What's the disadvantage? It's not easy to change. Then I selected some good cases to start, especially male patients, which the most common complication is residual hump in this technique. So male patients can tolerate easier. And also I started with the patient which likes stronger dorsum, because I started with just high septal strip. I didn't have any experience with others, because my teacher is Dr. Yves Saban. So he taught us high septal strip. I respect him. Actually, I still do a lot of high septal strip, but I explore also some other septal works can work better in such kind of situations, which I'm going to explain. So first of all, we have to understand, as I mentioned from the beginning, dorsum and septum, we have to separate in our mind. So once we check the patient, we can decide group 1 for easy dorsum cases, but it depends on the septum, what we are going to do. We have to decide separately for the septum work. So if we decide for septum, for example, high septal strip, we have to decide for the dorsum something else maybe. So it's a combination. So once we are talking about preservation rhinoplasty, we have to name the technique with septum and dorsum. And we have to write on our report that I did this one on the septum, this one on the dorsum. It can be cartilaginous preservation. It can be Ishida on the dorsum.
Yeah.
And Miguel is doing from Portuguese nice work. So it's different than others. Then we can choose the technique for the dorsum, and we can combine with low septal, high septal, or mid septal strip. So this is really important. I will pass. So Dr. Isavan, I want to thank him again for teaching me this high septal strip maneuver. So it's really important, and it's the easiest one I can say to start because it's simple and gives really nice results. Then you have to learn how to choose the correct candidate for this technique. It's really important. This is the high septal strip indications from my point of view. If the hump is not too much, it's less than 4 millimeter, and mostly cartilaginous hump, it works wonderful because if there is a S-shaped dorsum, S-shaped hump, you need to little bit reduce the hump. And if there's it's interesting. A lot of people are mentioning that if there's a high septal deviation, they don't prefer high septal strip. For me, it's opposite. And I discussed with Eve also. He is also thinking in my way, because when there's a high septal deviation, I resect that part. I take it out, and I solve the problem easier. That's why if there's a high septal deviation, I prefer this technique. This is easiest solution in my hand. Then if there is an over-projected radix, this is also easier, because once you resect a lot, you are solving over-projected radix problem by itself. And if the caudal septum is on the midline, of course, you can extend this in indications, but caudal septum is main support for this technique because it's carrying all the structure. So I have to trust my caudal septum. That's why I prefer if the caudal septum is on the midline, this technique. If the nose is straight, of course, you can do some small crooked noses for this technique. You can overlap. As Carlos is doing with his Tetris maneuver, it's also nice maneuver for me. But every technique has some advantages and disadvantages. We have to know all of them, and we have to choose for our cases. And if there is a V-shaped nasal bones, I prefer high septal strip. For example, this is a good candidate for high septal strip for me. When I started my way, I was already using piezo. On the middle, you can see Olivier Gerbeau from Paris, and I want to thank him also to give us opportunity to use piezo. So because of piezo, I encouraged to start this technique actually. Otherwise, maybe I would not start, because I need precise cut on the bone. Who is not using piezo, maybe they don't have experience. So I will just explain easily what is piezo. Piezo is just cutting the hard tissues as the eggshell here. This is raw egg, uncooked egg. I can just reshape the calcified part, then inside is intact. So it's really important to use this tool for me in preservation rhinoplasty. And this is a basic 3D diagram for high septal strip. Who is interested, they will easily understand now. We are not touching the dorsum. We are not undermining the upper lateral cartilages. We are just excising the strip immediately under the hump. This three-dimensional explanation is always easier for me. Then we are doing our osteotomies, then pushing down the dorsum, resecting the Webster triangle a little bit here, because it can overlap with the inferior turbinates bone. Okay. I just want your attention. When I do this technique, I didn't know that there is some spring effect. If someone always calls it spring effect, because some of our cases, the hump is jumping back.
Yeah.
Not now. It was jumping back at that time. So I had some complications with residual humps because of not selecting correct candidates, also because of less knowledge about the technique. Now I want to show you again this maneuver. Once you push down, look to the side wall. Do you see? There is a
Yeah.
separation because this is three-dimensional anatomy. Once you push down, if you don't relax this side wall, you can just push down the hump as it is. You cannot change the shape. You can just push down. If you want to change the dorsum's shape from the kyphotic to the flat, you have to do something on the side wall. It was really important point for me. That's why I'm talking about this maneuver now. So once you resect the strip, you can push and make a straight dorsum, or you can excise more, then you can create even curved dorsum. But it looks on the cadaver nice, but in reality, once you take out the instrument, it jumps out. There is a resistant point. And resistant points are not only one. There are some different resistant points. If somebody are interested in preservation rhinoplasty, they have to learn and understand this anatomical landmarks for this technique, because we educated with the dorsal hump resection and lateral osteotomy. We learned a lot how to reconstruct the middle wall, but now we are talking totally another way. We are doing another things. So we have to pay attention to anatomy again. That's why once you ask me what you want to talk, I want to talk about anatomy of the preservation rhinoplasty. We have to pay attention where is the thickest part of this maxillary bone. Because once you push down, it has to overlap. What we were doing, we were holding our osteotomes and cutting them on horizontally, and we were creating this layer here. If you want to push down, you have to squeeze the dorsum, and you have to push inside.
Yeah.
But it can jump out because there is a resistant point here. Where is the resistant points? The first is on the level of the medial canthal ligament here. Do you see the thickness here?
Yes.
The bone is thick. It cannot overlap. First resistant point here. Another is on the Webster triangle. This is not so important. We are usually resecting this part. And this is the bone of the inferior turbinate here. That's why we are resecting. And that's why I decided to my osteotomies sagittally. Once I do sagittal osteotomy, it drops down by itself. You don't need to squeeze, and there is no tension. This is really important. Once you hold your instrument sagittally to the bone, it goes down easier. So the first rule, when I do let down, push down procedure, I hold my instrument sagittally. And the second important thing, if you're dealing with the crooked noses, and some crooked noses are really easy to treat with preservation rhinoplasty, the first rule, you have to choose the correct candidate. The facial asymmetry patients are the best candidates. Once you look to the face, you can understand easily one side is short, another side is long, and usually nose follows the shorter part. This is another example. Nose follows left, and left side is shorter. And another example, left side is short, right side is short, nose follows the right side. What we want to do on these cases, we don't want to change the dorsal aesthetic class. We want just to tilt the nose to the longer part. Then what we were doing before, we were making the excision asymmetrically, and we were trying to fix it without fracture. It was working, but it was a hard job. And now what I do, one side sagittal osteotomy, another side horizontal osteotomy is a classical way. Once I do this, it fixes by itself easily. So I don't need to resect anyone. I just do sagittal and horizontal osteotomy combination. This is really important. That's why I showed that cases. I will pass this video. Okay, this is how I do my sagittal osteotomy. I hold my instrument perpendicular to the bone. So I cut the bone with my piezo instrument sagittally. Actually, piezo is excising a piece of bone. When you work with piezo, you will understand. So there is a gap between this bone, so it overlaps easily. It's not like classical osteotomy. Then after all these things, this is an example of crooked nose correction with preservation rhinoplasty. From the side view, this is high septal strip. Another important maneuver I learned from Dr. Yves Saban when he taught me the technique. He mentioned this maneuver. We have to undermine the internal periosteum of the maxillary bone, because whatever you do, there is a resistance of the mucosa inside of the nose. So we have to undermine. What we do now, we did sagittal osteotomy, we did undermining of the maxillary bone in internal layer, but as you see on the cadaver, I did everything, I'm pushing down, I have still residual hump here. Do you see? It's clear.
Yeah.
So we cannot change the shape. Still, there is a hump. It was always disturbing me. Then I decided to make dissection on the lateral wall. So I did a lot of cadaver dissection. So I checked on the cadaver first. Once I make, this is 15 blade, but I'm not using 15 blade in the real surgery. I do use elevator, freer elevator. So I don't cut any structure. So it's actually in the book, Preservation Rhinoplasty book, this ballerina maneuver. So once you see this red line, and if we undermine the lateral wall, it's just the longitudinal preformed ligament dissection, not the vertical one. Vertical preformed ligament is intact. So this, after the Webster triangle excision, as you see this triangle here, this is really easy because you can see the edge of the bone with the freer elevator. Once you feel the bone, just push up with your instrument. It's easy. You're not cutting anything, you're just undermining. And this lateral dissection solved a lot of problem of residual hump in the technique. As you see, this is before, this is after, and this is the separation of the lateral wall. There is overlapping here, so you cannot get any weak point, because here there is no cartilage. There is just longitudinal preformed ligament, and cartilage is here, which is supporting the lateral wall, and overlapping is about 5, 6, sometimes 1 centimeter here. So you are not cutting the cartilage. I'm just mentioning this because there are some questions. Once you push down, now you will see that there is no residual hump. You're pushing down, lateral wall separation, and the dorsum is flat.
Amazing.
So this maneuver made sense in my surgery. So I had almost no residual hump if I choose the correct candidate. If I choose S-shaped dorsum, and if I don't resect the S-shaped dorsum, of course, I can end up with the residual hump. This case was the first case I did with Dr. Yves Saban. He did the close approach dorsum. I did the open approach dipplasty. So it was a combined approach. Fast about 3 years. I think we don't have time. I will go fast about these examples. I think I mentioned all small tricky points and anatomic landmarks. And let's don't talk about low septal strip. I know that it's also interesting, but it takes more 1 hour because Gene Kern encouraged me to start low septal strip. When I discovered low septal strip, I realized that sometimes it's better for crooked nose correction because you can do a lot of nice maneuvers on the septum. So cotal septoplasty works better. So there is also one more septal approach, mid-septal strip, but we completed already 1 hour. I think we can answer the questions if there is a question.
Okay. Yeah, it was really fantastic, Professor Göksel. Not only your results, but the way you exposed here was like your evolution, right? When you started, what problems you faced, and how are you now, and how what were the tricks that you found to treat the little complications like the bump recurrence. So in our practice, especially for people who are starting preservation, I think that's one of the highest rate of revisions, the hump recurrence. And you showed there in a amazing video in the cadaver dissection exactly what happens during the surgery. Sometimes we did everything and there is still a little hump, and then we go with the chisel there and release a little bit, and it goes flat. So it's like magic there, and it's
Yeah,
amazing.
it's important. Especially who is doing surgery, we have to understand the anatomy. It's really important. That's why I wanted to talk about mostly anatomy today,
Yes,
because anatomy is the same, but we are looking from different perspective now. So that small details were not important before, but they are important now because we are doing different approach. We have to understand. And also, anatomic dissection photographs and videos are really helpful to understand what happens in the surgery, because sometimes we confuse. There is a bleeding, and you are in hurry. You don't understand. You cannot cut the tissue, and it's very important to understand with the cadaver lab photographs, videos. And as I told you, there is no only one way, correct way. There are a lot of different ways. I do also structural rhinoplasty a lot. I mean, I do a lot of revision rhinoplasties, by the way. So I do a lot of structural. And you know what's interesting and nice? We combine these two ways. So I do structural rhinoplasty with preservation rhinoplasty techniques. It's
great.
wonderful. So that's why I'm happy that I started preservation rhinoplasty, and I am a little bit experienced now comparing with beginners. But on the other hand, we are just starting. So all of us. So it's a new game. It's a new tool for us, and everybody will add some important small maneuvers. So we will improve all together.
Yes, that's great. Talking about the septal work, so your preference is for, of course, depends on the indication, but in your patients, do you do more high septal strip or more low septal strip?
I do both. It depends on the case. It's a good question because actually, from the beginning, when I read articles, when I read somebody's way, they are explaining their technique, exactly the same work on the septum and same work on the dorsum. But it's not really like that because septum has to change depends on the septum pathology. And dorsum work has to change depends on the dorsum pathology. There cannot be only one way. So on the septum, and if the septal lesion is exactly on the lower part, why I have the septal strip, the low septal strip, I exercise that part to solve the problem. Then, for example, there is a quick nose. If I want to change the connection between the anterolateral spine and the caudal portion of the septum, anyway, in low septal strip, I'm disarticulating this area and I'm refixing again, and I can find the solution for fixing better. Then it depends on the case. I do both. I do high septal strip, I do low septal strip, and I do also mid septal strip. Like actually, it's not typical mid septal strip. That this concept of Carlos when he gave the IRA. When he talked about it, I immediately have some nice feeling about the technique because it's the between coastal and works really well if you choose the correct candidate. But as I told you at the beginning, all techniques have some disadvantages and advantages. And it's an easy way to fix, it's easy to apply, but on the other hand, you cannot harvest a lot of cartilage with that way. So if you need to harvest the cartilage or something else on the camouflage, and get better to do high strip in that cases, because high strip gives you opportunity to get more cartilage from the
All right. Okay. That's great. Let's answer some questions, Dr. Göksel. I'm gonna open here for questions. I'm sure that there are many good questions here. Um, yeah, and yeah, some Lucepto. Yeah. There's a friend here that is asking you to detail a little bit the septal strip excision. How do you do that?
You mean high septal strip excision?
Yeah, it doesn't. He didn't say, but maybe you can talk about the high septal.
Actually, I showed the video 3D, but I can mention again. On the high septal strip technique, there are some tricky points. The first tricky point, you don't have to touch at all the caudal portion of the septum at the beginning. So you have to keep it intact. And you don't have to excise a lot from the ethmoid bone, perpendicular plate. So you know why? Because you have two bridges which is carrying the dorsum. The one leg of the bridge is caudal portion of the septum. Another leg of the bridge is the perpendicular plate of the ethmoid bone. So we have to keep them intact at the beginning. We can resect between just immediately under the hump. And please be careful, resect incrementally, slowly, because you cannot turn back, but you can reduce more. At the end of the procedure, you can resect from the caudal portion of the septum if it needs, because that part usually, if you get used to use hump reduction techniques, open root techniques, usually what we were doing, we were excising from the beginning. Then we were creating the tip and creating the supratip break. But in this technique, if you resect a lot from the caudal portion of the septum, you can get settled in the supratip area. That's why these are the important points for septal strip excision on the high septal strip.
When you talk about you're combining preservation and structure, you mean mainly that you're doing dorsal preservation and structuring the tip, or it's a different way of?
Yeah, exactly. No, exactly. Also the septum. I mean, you have to do some structural work on the septum sometimes. You need to do. I mean, sometimes extracorporeal septoplasty can be combined with preservation. Also, you can preserve the dorsum and the extracorporeal. It's a structural way. But when I'm talking about the structural way, mostly I'm talking about tipplasty, because sometimes I need to use lateral cross strut graft or cap grafts or something else for the tip. So we have to learn all these tools. We have to collect the tools in our toolbox. Then when we need, we have to use them, because some cases needs more. But tipplasty is tricky. Lateral steel works really well with a lot of cases. But sometimes you have some weak cartilages, you have to support them, you have to add additional support, then you have to combine the structural techniques with the dorsal preservation. But it's not just about dorsal preservation. Still, you can preserve the ligaments. Then ligaments preservation helps you to heal faster and better.
Great. And all right. And this is an interesting question about the ballerina maneuver. Um, what is your limit superiorly?
Superior limit is the dorsal keystone area. I mean, you have to draw the dorsal aesthetic lines, which creates by the upper lateral cartilage and the connection with the nasal bones. So you don't have to cross that border, because let's say easier way, because a lot of complicated explanations cannot help in the practice. The easiest way, mark the hump which you want to remove, then don't cross that line till the hump you want to remove. Usually, if you mark at the beginning, you can see that line. But still, you can use practical way. You can do incrementally. You can do a little bit on the posterior part. Then you can feel there is a resistant or not. Then you can do more and more. If you do incrementally, I think it's even better.
Great. All right, a question here from a friend from Istanbul. If you preserve the scroll ligament and the widening happens at the scroll area after the push down, how do you manage that?
It's a good question because usually if you don't release the lateral keystone, it happens, especially in high septal strip cases, because once you push down, it makes widening. But if you separate the lateral connection, if you do ballerina maneuver, it doesn't happen because ballerina maneuver also solves this problem because it moves this way. Is it clear to understand? Because my hands are not so
Yeah.
good. It's not three-dimensional explanation, but I can say like that. If you don't undermine the lateral keystone, you push down and make widening. But if you undermine the lateral keystone area, it goes this way, so you don't make widening.
All right. And sometimes you fixate the dorsum with sutures.
Actually, most of the cases I prefer to fix the dorsum. I had no time to talk about it. If I do close approach, if I don't undermine the dorsum, I fix the dorsum like Teoman Doğan from Istanbul. He has a nice suture. Actually, we had kind of suture, but he solved the problem a little bit tricky way. So it works well. I prefer his suture technique. And on the other hand, if I undermine the dorsum, I prefer crisscross suture. I make a hole to the nasal bones and I make crisscross like Gubish is doing for his extracorporeal septoplasty.
All right, great. And also because you were the father of ballerina maneuver, a very friend here in Brazil, very good friend. Pablo is asking, have you ever thought about making some little holes and stitches between triangular cartilage and the bone to prevent a recurrence, or when you do the ballerina maneuver, it's over and you don't have recurrence?
It means that osteotomy line, Milos Kovacevic from Hamburg, he had an idea he was using and he was presenting this actually, not the cartilaginous piece, but the bony part of the septum, vomer, piece of vomer, he was planting to the osteotomy line, so it was fixing. But I prefer to make it relaxed because there is no way can resistant to nature's force. So if there is a force, if there is a resistant point, I think we have to kill that resistant, then we can get the result. If I understood correct this question, I don't know.
All right. And when you compare the Dr. Saban's high septal strip with Dr. Miguel technique, comparing the advantages and the disadvantages, how do you think about that? Do you think it's
Actually, it depends on the case. Miguel's technique works really nice also. They are both using high septal, but Miguel is keeping intact all the cartilaginous frame. So he is doing osteotomy and closing again. It's like Ishida. Ishida is doing the same similar way. But Ishida is sometimes keeping intact the bony cap. So he is doing osteotomy around. But anyway, the philosophy is similar. I prefer, if I can, I prefer not to touch the dorsum because the main idea for me keeping intact all the dorsum because there is a wonderful, beautiful anatomy. When I resect the bone, there is always some irregularity. You have to put some small camouflage, and sometimes not, but mostly you need to put some camouflage this keystone area transition zone because the skin is so thin there. If I can preserve all the dorsum intact, I prefer to keep it intact. That's my philosophy. Of course, the both technique works, and also some cases you have to resect because sometimes you have S-shaped dorsum. So actually, most of the population has S-shaped dorsum, by the way. So that's why Miguel is doing almost all cases with this approach. But you can combine with low septal strip also. I mean, as I mentioned, we don't have to fix only one technique in the septum. So you can do Miguel's preservation on the dorsum. We can combine with low septal strip if it needs. I mean, the technique should not be just with only one single method on the septum.
all right? And one more question here. Uh, when you do mid septal strip, do you think sometimes the higher part and the lower part can go like this and create some deviation?
Yeah, it can actually. It happens, but sometimes it's advantage if you are dealing with the crooked nose. You're overlapping and fixing the problem easily. But if the nose is straight and if you don't want to change the direction, it's a risk. Then what we can do, I was discussing with Carlos also about this issue. We can put the thin layer ethmoid bone fragment and fix it with it. And but if you fix nicely, kind of figure eight suture, crisscross suture, I think you can protect this complication overlapping. But on the other hand, it's a good technique. I use this mid-septal strip, especially when I'm dealing with the crooked noses. If the crooked nose is not severe, I don't prefer total in that kind of cases. I just overlap. So I do mid-septal strip. It's easy.
All right. And a question here from Dr. Honshi, very a very famous professor in Brazil of structural rhinoplasty. He's asking, when you release the lateral key area and you keep just a small connection on the top, and if you think it's how safe is that to avoid any depression or deviation?
Actually, I answered this question in the presentation. There is a overlapping, the big overlapping on the lateral keystone area. Actually, when I decided to do this maneuver, first I suspected to have the same thing, like in the question professor asked. That's why I did the cadaver dissection a lot. Then I see that the overlapping is always protecting the lateral wall. Because once you do that maneuver, you're not opening like this. You're just changing like hinge. It works this way. So there is always overlapping. So it protects the lateral wall.
Great.
I had no problem actually.
Great. And one more question here. How do you do and what suture do you use to refixate the Tangi ligament?
Uh, Usually I use 5-0 PDAs, but sometimes if the patient has thin skin, sometimes even 6-0 can be helpful.
All right. And um, you're for beginners in preservation rhinoplasty. What is the technique that you recommend?
I think Alessandro is asking. Hi, Alessandro.
Yeah, Alessandro.
Okay, for that, I recommend to start with high septal. This is the easy one, nice result, and easy to learn. So high septal street is the easiest one because low septal street is more complicated, and you can get more complication with low septal street. Better to start with high septal.
All right. And one question here. What do you think about overlapping of triangular cartilage, like we do it in the medial crura?
It depends where to overlap actually. Sometimes it can break the tension. That's why in the medial crura is less risky from my point of view because you are adding also columellar strata and fixing together. But on the other hand, if you use this technique on the side walls, it can break the tension, so it can create some breathing difficulty, external wall difficulty problem.
All right. And I think you already talked a little about that, but one more question here regarding the high septal street and how much cartilage can you harvest? How much septal cartilage?
I think I had one slide about it. I can share my screen and show how much cartilage I can harvest with high septal strip because it's easy to understand. I will show you one photograph. Oops. Okay. Yeah, this photograph shows really nice. I'm trying to share my screen now.
Okay.
Okay.
Yeah, that's it.
Okay. As you see, this is the caudal portion of the septum untouched. I didn't trim. So this is the resection of the high septal and all the dorsum removed. So you can harvest this piece of cartilage like in regular septoplasty. That's why high septal strip gives opportunity to harvest a lot of cartilage. Because once you cut here like Tetris, you have to keep intact the piece of cartilage here so you can collect a little bit less. Or if you do cottle, of course you can still harvest the cartilage, but not this much. That's why high septal strip is the best to harvest the cartilage.
Great. Yeah, let's go one more question here. What percentage of your primary cases you do preservation? But actually, maybe when do you decide to do structure if you your preference is for preservation?
Actually, I showed the diagram how I decide to preserve or not to preserve. First, I ask myself, is there something to preserve on this case?
Yeah.
On the especially on the dorsum. So if the question is yes, I do preservation. But in my practice, I do a lot of revision rhinoplasty also, and I prefer to do it open way and structural way. And also some primary cases, especially traumatic noses, no need to struggle because it's better sometimes to remove and rebuild. Then I do structural from the beginning. I don't struggle with the preservation and I don't want to change my way in the surgery. And still, I do 50-60% of my cases with structural rhinoplasty and 40-50 I do preservation rhinoplasty.
Great, great. How do you reduce hanging columella?
Hanging ala.
Hanging ala, sorry.
Okay. So hanging ala is a really tough point to answer because sometimes it depends on the position of the cartilage, but mostly it's about the skin, heavy skin and thickness on the low lobule. And telesubcutaneous cutis is really interesting tissue which we have to deal in this kind of cases. So I do sometimes skin excision on the rim here, but sometimes like sail excision inside of the vestibule can help. And also you have to combine with some reorientation of the lateral crura. Sometimes it's also because of the position of the cartilage, but mostly about the skin excision and from the vestibular skin. I don't like to excise the skin on the rim. It's tolerable to have scar here if you warn the patient at the beginning, but anyway, there will be always scar on the rim. So I don't like to see any scar. That's why I prefer to excise from the vestibular skin. Right. But you have to be careful. If you excise a lot, you can create some retracted ala. And on the other hand, there is a hairy skin inside of the vestibule here. So it's better to excise on the borderline transition zone between the mucosa and the hairy vestibular skin. So we don't have to excise close to the rim.
All right. And yeah, about complications, Dr. Göksel. Dr. Cordo is asking, what are most common complications in your hand?
Probably this question is about preservation rhinoplasty.
Yeah.
Okay. Not just in my hand, the most common complication of preservation rhinoplasty, especially dorsum preservation rhinoplasty we are talking about now, the residual hump, which I think we solved a lot of problem about it with the small details, the sagittal osteotomy, blurry maneuver, undermining the internal layer. So there are some small tricks which we can protect ourselves. Also, the most important point we don't have to forget to mention, choosing the correct candidates, because if there is a S-shaped dorsum, it means that if there is a kyphotic nasal bone here, and we have to be careful, we have to remove that, and we have to choose the correct technique for that kind of cases. Sometimes we don't need to preserve. And the second most common complication in preservation rhinoplasty is small step on the radix. If you cannot manage the radix osteotomy nicely, you can create some small step. In that kind of cases, it's easy to treat actually, because you can use some dice or paste cartilage, which I use a lot with PRF. PRF we are using a lot with Dr. Milos Kovacevic. He started to use PRF and he taught me, and I decided to mix with the paste cartilage which we were using before. Then I usually inject inside of the PRF gel, and I call it Turkish dumpling. So I implant the region which I have stepped. But usually it's not so common in my hand, because first period when I started preservation rhinoplasty, I had some step on that radix area. But nowadays, almost no cases, I don't see any step, because I use oblique version osteotomy, so I create the hinge there. And this third common complication, it depends on the technique. Low septal strip or high septal strip, you can cause some depression on the supratip area if you resect a lot, or if the cartilage is weak, because weak septal cartilage cannot support your old structures. So you have to support with some ethmoid bone or additional splinting grafts, the caudal portion of the septum. But I can say that all techniques you can have some complication. I mean, preservation rhinoplasty has its own complications. Also, structural rhinoplasty has a lot of complications. Why I do a lot of revision rhinoplasty? Not just because of preservation rhinoplasty. I do a lot of revision rhinoplasty of previous structural rhinoplasty results. It means if you're careful, you can get good results. But if you make mistakes, of course, you can get complications. On the other hand, when I compare the complications of structural rhinoplasty and complications of preservation rhinoplasty, usually preservation rhinoplasty complications are easier to treat, because small defect here, you are putting camouflage. Sometimes you can inject fillers if you don't want to operate, and if patient accept. And residual hump problem can be treated easily with the secondary operation. You can rasp, or you can do additional procedure for preservation. You can push a little bit more, and you can make the ballerina maneuver. Then you can treat the patient. So comparing with the structural, in my opinion, this preservation rhinoplasty complications are easier to treat. But of course, it depends on the case. It depends on the surgeon. It depends on the experience.
Great. All right, Dr. Göksel. Just one last question here before we finish. How essential do you think it's piezo for your preservation rhinoplasty?
For me, piezo is kind of my right arm now, because I feel so comfortable with piezo. But on the other hand, very, very experienced surgeon, very, very good result he is getting. Yves Saban, he never used piezo, so he has good results. But for me, really important to make a precise cut and precise job on the bony part. So I want to be sure exactly where am I. So osteotomy level is also important. That's why I create that tunnel and I see the fascial groove, because if you do your osteotomies a little bit higher than the fascial groove, you can create step. But on the other hand, if you're experienced with osteotomes, if you manage your osteotomes nicely, of course you can do all osteotomes with your osteotomes. But in 100 case, if it happens for the one case in 100 case, unwanted fracture lines. So I ask myself, do we have this right to do that patient or not? Because when it happens to that patient, 100% it happens for that patient.
Yeah.
For you, it's 1 in 100, but for the patient, it's 100%. So I think if there is a tool which you can use precisely, I think it's better.
Yeah. Great answer. Yeah. All right, Professor Göksel, I know it's late at night in a Saturday evening in Istanbul, so I'd like to thank you again for all your time and opportunity to have this great moment with you. You really shared some very important knowledge with us, not only your good results, but you also talk about some of your complications and the tricks how to deal with them. And that's something that really makes a difference for us. So thank you so much for sharing your knowledge. Just like to thank you for everything.
Thank you very much for being with us, and thank you so much for the invitation.
Yeah, and just a little advertisement here about the meeting, right? The meeting that you're organizing next year, which will be
Oh, yeah.
remarkable, right?
You're all invited to Istanbul for 2021 in June. We are going to organize structure preservation rhinoplasty meeting. We are the chairmen with Dr. Boris Checker, and we have two big bosses, Dr. Dean Torimi and Roland Daniel. They will be with us. And also, I want to thank again to you for helping this organization, because you deserve this thank.
Oh,
And hopefully 2021 will be better year for all of us, and we are all enjoying in webinars, but trust me, real meetings are better. because
yeah.
because the weather condition in Istanbul and beauty of the city is something not to miss.
Oh yeah, I totally agree. I've been in your wonderful city for 5 times, and I really love your city.
Yeah, you're welcome. So hope to see you all in Istanbul next year.
All right, Professor Göksel, thank you again. Um, Thank you for everything. Okay, have a nice.
Thank you very much. Have a perfect day. Bye bye.
All right, bye bye. Okay, and I'd like to thank you all guys for being here again. This amazing lecture, amazing meeting with Professor Göksel. You all saw how great he is, not only as a surgeon, but also with his mindset of a growth mindset of always pushing himself to his limits and trying to solve or to find better ways to give better results for his patients. So that's probably the secret of the greatest surgeons. So thank you so much. Obrigado a todos do Brasil, gracias a todos de Latinoamérica. Una vez más, un evento muy bueno para todos nosotros. Thank you guys. Bye bye.